All right, I'll just give it 3 more seconds. Most people log in right at 8, if that's all right. Diane, are you able to hear me okay?
Am I what? I'm sorry?
Are you able to hear me okay?
Yes.
Great. All right. Well, I think we can go ahead and get started. I'm really glad you can join us, Dr. Chang, to talk to us, to give us more of a global perspective on aging. And I think Dr. Ruru Wang, who invited you, it sounds like both of you were doing some work at IHME here at the University of Washington at the same time, but for everyone, Dr. Angela Chang is an assistant professor at the Department of Clinical Research at Southern Denmark University. She has her master's from Johns Hopkins and then her doctoral degree from Harvard, and then did work at the Institute for Health Metrics and Evaluation at the University of Washington, which is something all of us are very familiar with these days because of their work on COVID-19. But she really has broad research interests in global health and health economics and health metrics. And I'm going to let you take it from here. Thank you so much for taking the time with us today.
Okay. All right, I'm going to share my screen so you can all see. And can you all hear me okay?
Yes, we can hear you just fine.
Great. Well, thank you for the invitation. Today I'm going to talk about measuring population aging. So it's very much related to what your group is interested in, but slightly not from an individual perspective, but from a population perspective. And I'll give a quick background of myself and then talk about this one paper. The talk is mostly focused on this one paper that was published 2 years ago. But just quickly, as Dr. Bennett mentioned, I am right now based in Copenhagen as an assistant professor at the Danish Institute for Advanced Study. I came here a year and a half ago from Seattle, and so far very much enjoying my life in Europe, even though I miss Seattle very much. I am trained in health economics and health metrics, but I combine lots of different methods quantitatively in order to answer questions that I'm interested in. But the most important thing I'm trying to do and trying to slowly get towards is to do research that have real life impact. I think there is a spectrum of research that you can do, and I'm trying to get closer to real life impact as much as possible. So this talk is going to be based mainly on this paper, which you can find in Lancet Public Health that was published in 2019. And we received lots of interest from all over the world, from policymakers, from the media, from academics, of course, from clinicians. And so I'm quite pleased that people were interested in this. And I think there's a demand for better measures of aging, as I'm sure your group, you've all thought about quite a bit. And I'm not going to go into the details of the methodologies. Those, if you're interested, you can look on the paper and the appendix, especially of the paper. But I'm just going to talk about more the general concept and the key findings of this. So the first question to ask all of you, even though I can't see you guys, is, imagine there are two people, two individuals. One is age 65 and the other is age 75. Who is older? And of course, you know the answer. If I change the question to who is healthier, then you have to think a bit. So it depends on the person's status, functional status, health status, and so on. So age itself doesn't really tell you so much. And now, if you think about at the population level, imagine there are three populations. The first population on the left has 28% of the population age over 65. The second population, 16%, and the third population, just 3% over age 65. So which population is healthier? And it's a difficult question to answer, I imagine, and which is a more aging population? Again, the answer, some people might directly say, oh, the 28% is aging population, but I'm going to tell you otherwise. And these are actually real countries. So the left is Japan. Japan has 28% of the population over age 65. The US has 16%. Papua New Guinea has 3%. And now that you see the answer, you know that which country is which, would you still keep the same answer that you had in your mind earlier? And so with these simple questions, I hope I've illustrated that aging is especially population aging, is a difficult term to define because it is and should not be just about chronological age. Yet, if you look at policy global reports and studies on population aging, the most common metric of population aging is tied to the chronological age. For example, on the left, you have WHO, and on the right, you have median age of Europe, and everyone says, oh, populations are aging, but they mostly mean the age, the chronological age of the population, and not necessarily the health status of the population. And so when I was reviewing this literature, even before this, actually for my PhD, I was working on a project on multimorbidity in older populations, older meaning age 40, which is a very strange cutoff, but populations that are over 40 in South Africa. And I kept wondering how do you define old age? What is the threshold? And so I started looking into the literature and I found sort of two sets of literature. One is population metrics that I've listed here that are mostly related to either how long you live or like life expectancy or the size of a population over a certain threshold or arbitrary threshold of age. Then there's another set of literature that's more based on individual characteristics. So they include frailty, cognitive, physical functioning, activities of daily living, limitations in those, and so on. And in my mind, these individual characteristic studies are more reflective of what in my mind, true aging means. Yet we can't really do these kind of studies in population level because data collection is very difficult and difficult, expensive, and so on. And so, the healthy aging, as people commonly define it, is the maintenance of physical and cognitive functioning. And the later the onset of these functional declines, the better. And so along with my colleagues and I, we thought about trying to develop a valid and comparable population aging metric that also reflects some of the individual characteristics that I mentioned here, so more on the health status. And just to drive this point, so if you think about an adult in the US who's age 65, compared to a 65-year-old in Japan, or compared to a 65-year-old in Papua New Guinea or Ethiopia, for example, you can easily imagine that they're very different. Similarly, a 65-year-old in the 1990s compared to a 65-year-old currently, even in the same country, or you can imagine are very different. And so just using increase in age as a definition of aging seems arbitrary to me because it doesn't reflect the full functionalities that the changes that people go through. And so one way that we thought about doing it is using the global burden of disease data that IHME produces. And some of you may be familiar with that, and I'll talk a bit more about that. So this paper was published in 2019, and we received lots of interest from popular media. I think people are just interested in these kind of rankings of countries, and even though I don't think that's the main purpose of these kind of papers, but people are interested in comparing which country is doing better or worse. And I'll briefly mention the methodology here, just so you know how we did it. But again, the details I will not go through. So GBD, global burden of disease, has, they estimate disease burden, so mortality, morbidity, and the sum of them from 1990 to latest year. Over time, by different age groups, by sex, across countries, there are subnational level data as well. And so what we did was basically we choose among close to 300 diseases of GBD diseases. We choose which ones we consider as age-related disease, and I'll talk about that. And then we just add them up and we define it as age-related burden. So the way we choose the disease is by looking at the global incidence or prevalence rate by age. And if there is an exponential relationship between age and prevalence or incidence, we consider it age-related. So on the left, you have colon and rectum cancer, and you see this very clean exponential curve by age over time, and so this is included. On the right-hand side, we have diabetes, which some people consider as aging. But in fact, if you look at the global level, incidence actually does not increase exponentially with age. So diabetes is excluded. And there are some diseases that, when you think about it, you think they may be related to aging, but in fact, they are not if you look at these data. And we did a sensitivity analysis on these. There are maybe 10, 15 diseases or so that many people ask when we're presenting, like, why isn't this disease really included? And we did a sensitivity analysis and the results don't change too much, but I'm happy to talk about it later. So out of 293 causes at that time, we chose 92 age-related diseases and add them up together and consider that an age-related burden. And this is just a list of all the diseases. I'm not going to go into detail, but cardiovascular disease and cancers account for close to 50%, or in some countries over 50% of their age-related burden. The next, I think, was chronic respiratory disease that account for about 10%, but it depends on the country. So I have 5 messages, key messages in this paper. The first is that age-related burden is a huge proportion of all burden among adults. So in this study, we only look at adults 25 and above. We don't look at anyone below 25. And as you can see, so on the x-axis are different. The first column is global, at the global average, and then we have different social economic development status of countries. So SDI is just a thing that IHME uses, but it's very correlated, highly correlated with income and development. On the y-axis, I have age-related DALYs, disability adjusted life years, which is a sum of mortality and morbidity rate per 1,000 adults. And so the whole bar is all the burden that the country adults have. And then the darker pink is the age-related burden. So globally, about 50% of all adult burden is age-related. But you can see some differences in different countries. So high income, we tend to have lower overall burden as well as age-related burden. And I think what's interesting is that even in countries that we don't think are typically aging, for example, low income countries, 50% of their burden is still age-related. And then if you look at countries, even though I don't present it here, the difference between the highest and the lowest country in terms of age-related burden is quite high. So the highest, the country with the highest age-related burden is Papua New Guinea, and then they have 4 times the rate of age-related burden than the lowest country, which are Japan and Switzerland. The second key message is that age-related burden is actually decreasing over time everywhere. And this is contradictory to what we often hear in the media, where we say, oh, everywhere population is aging, and therefore countries have to be careful and devote more money to aging-related issues. And it's not wrong, but if you look at rate, so per person, per 1,000 people, for example, it's actually decreasing over time. What these messages usually are saying is that older people, defined by age, is increasing. But whether their health status is declining or not is a different issue. And in my study, we show that actually older people, meaning people with more years lived, are actually healthier than before. So here you see on the x-axis, this is a change over time, change between 1990 and 2017 of age-related burden in different socioeconomic status countries. So globally, we have seen in this time period a 23% decrease in age-related burden. In high income countries, we see larger decreases. In lower income countries, we see slower decreases. But regardless, even the lowest decrease is 18%, which is quite high. And in some ways, it's not surprising, given our broader knowledge of the fact that population health is becoming better everywhere. However, globally, our focus has mostly been, in global health, has mostly been around child and maternal health and the improvements in child and maternal health. And we often don't talk about, in fact, the adult population, adult health, and even older or age-related burden is actually improving as well. The third key message is that age-related burden is decreasing, largely due to decreases in case fatality and disease severity. So here we did a decomposition of the change that you saw earlier. What factors attributed or are associated to the changes in the decrease in age burden? And here is slightly different. So on the x-axis is the actual absolute number of burden and not the rate. But this is a detail. But you'll see 4 different colors. Green is population size, yellow is population age, red is prevalence, and blue is case fatality and disease severity, meaning, for example, for the same cancer, same type of cancer, the severity of the cancer may decrease over time or change over time. In IHME, the GBD dataset captures that. And so typical discussions around population aging involve conversations about the changing size and age structure of older populations. And this is partly supported by our analysis, which found that the increasing size of the adult population, so the green bar, is one of the largest factors associated with increasing age-related burden between 1990 and 2017. However, far less attention has been placed on the variation in prevalence and disease severity. So prevalence in our graph, as you see, the pink is not so big. So the prevalence of these age-related diseases haven't changed too much over time. What's changed a lot is the severity of the disease. So for example, GBD captures the distribution of time spent in 4 phases of cancer. So there's diagnosis or treatment, remission, metastatic, and then terminal. And what this shows is that for some diseases, the severity has changed quite drastically for some diseases, and therefore age-related burden has decreased, even though prevalence may be the same. So maybe the same amount of people or same rate of people are getting the same, are getting cancers, but the severity has decreased over time. One thing that's interesting is that the change in, like, for example, the blue bar relative to other colors in low-income countries are smaller. And my study can't tell you more about this, but my hypothesis is that the benefits of treatment has not been accrued as much in some countries. So in high-income countries, we've gained a lot. So the decrease, the blue bar in high-income country is close to 50% of the whole bar. And it's much bigger in terms of proportion, meaning that we are getting more benefits out of these improvements in treatment, advancements in treatments over time than in other countries. The fourth key message is, again, to reiterate what I said earlier, and I still believe that, is that chronological age itself is a terrible metric for measuring aging. And this graph is mainly to drive home that point. So we conducted an equivalent age analysis, and we tried to show that in each country, at what age would one have the same age-related burden rate as the global average 65-year-old. And so you see on the right-hand side, the top countries are Japan and Switzerland. And then on the left-hand side, you have Papua New Guinea. And so in Japan, for example, Japan and Switzerland, what this graph is saying is that a 76-year-old Japanese have the same level of age-related burden as the average 65-year-old. In Papua New Guinea, for example, it's, I think it was 49 or 50. So a 50-year-old Papua New Guinean has the same age-related burden as a global 65-year-old. And you see the distribution of different countries. And I pulled out some numbers that people in the US are mostly interested in. So we have Japan and Switzerland on top, Canada at 73, and then you have some other countries. United States is at 68.5, so it's good but not great. And then Russia at 59.2. And so just to, again, to make sure this is clear, so even among high income countries, the differences are wide. So a 76-year-old in Japan had the same age-related burden as a 69-year-old in the US. So that's a 7-year difference. And then the fifth key message here is that even among countries with similar level of age-related burden, the onset of aging differs. The pattern of accumulating the burden across ages vary widely. Even though you may have the average population level age-related burden as the same level, the accumulation of the kind of the onset of aging differs by country. And of course, a later onset is preferable. So here we have an example of 3 countries, China, Saudi Arabia, and South Africa. They happen to have similar levels of age-related burden based on our estimates. But you can see that their kind of cumulative rate of, so accumulation of age-related burden by age is quite different. So you see, so this purple line is South Africa. So South Africans tend to accumulate more in the earlier ages. And then they then other countries sort of catch up around age 75, 80. So that means that even though they have the same population level aging burden, South Africans experience aging earlier than the other 2 countries. And this dashed line here is the frontier countries, meaning that at every age group, we looked at which country is doing the best, meaning that has been the lowest at this age. And the frontier countries are Switzerland, South Korea, Singapore, and Kuwait. Kuwait is like very high here. And so you see how the difference so if you're if you combine all the age groups, the best age groups from different countries, from these 4 countries that I mentioned, you get this curve. And then the difference you can see between the frontier and these example countries. And this graph, I'm not going to go through, but it's the same type of graph. And one of them is the US. I think the US is the dark line here, and this is the frontier. So the US has a, so there's not much difference in the early ages, but then you can see from, from age 40, you see a bit of discrepancy, 60, and then in the older ages, you see a huge gap between the frontier and the US. So what are some of the policy implications here? One is that I do think the current use of aging metrics that use age structure is not really informative. Of course, people are living longer. My current institute, there are many very good demographers. So I've been listening a lot about how demographers talk about survival. And on average, I think in the past couple of decades, every decade, at least in high income countries, there has been a 2.5-year increase in life expectancy, and this has not slowed down. So the trend is that everyone is going to live very long. Not everyone, the population is going to live very long in the coming future. And especially, they were saying that kids who are born in this decade, the life expectancy is going to be close to 100 for all of these kids. So it's incredible if you think about it. But of course, we know that health status does not necessarily follow age. And so an improved aging metric, I think, is really important to start using early for policymaking, because otherwise, if you just use a retirement age of 65, you're going to have people retiring at 65 and have 35 years of fairly good life expectancy, of good life years ahead. And that is not very useful for policymaking. Okay? So how health systems should adapt to emphasize these diseases that are age-related, how families can organize themselves around care of older generations who could be very healthy is important. And in order to do so, you have to have a good metric of better estimate beyond the chronological age. I think comparison across countries are interesting, but it itself is not interesting unless you do more about it. So I think there's lots to learn from countries, especially the frontier countries, on what they are doing well. How is it that they are better at preventing these age-related burden or delaying the onset of age-related burden to a much later age? And the last thing is that we found that the top diseases associated with age are, as I mentioned, cardiovascular diseases, cancers, and then COPD. And so if countries want to reduce age-related burden, focuses on these would be quite effective. That is all for my talk. I'd be happy to answer or discuss any questions. I may not have the answers because it's been a while since I did this study, but I'd be happy to discuss. Thank you.
Thanks so much. If anyone has questions, feel free to unmute, or if you can't, type them in the chat and I'm happy to read them.
I was wondering, Dr. Chang, do you think it's something related to the culture of the health in certain countries, of the health systems, or what is that about that makes, you know, Canada different from US?
Yeah, thank you. So one thing to note is that I think the first question I had was, well, how is this age-related metric related to the general health of the population, not just age-related burden, but any. So in fact, there is correlation, right? Because of course, our metric is roughly 45 to 50% of the whole burden of adults. And so in that sense, if you think about general health, not just age-related health, Canada and US, of course, have lots of differences in how they have prevention, treatment, and so on. But especially specifically for age-related burden, then you can look at the diseases that are related to aging. So primarily cardiovascular diseases, cancers. I don't know the specific details of specific countries, but I imagine that the usual suspects are there. So health systems, how whether prevention is starting early, whether treatments, I imagine Canada and the US have similar treatment options, so that may not be an issue. Early detection, maybe. So I don't have the exact answer, but I imagine the usual suspects are all there.
Thank you so much for being here, Angela. I was wondering if you could speak a little bit more to how differences change in the severity of burden. I remember you describing how with cancer related burden, how that severity has gone down, and that makes sense to me just in terms of the increased treatment options. But could you speak to a little bit more about how burden of aging severity would be described?
Mm-hmm. Sure. So for those who may be familiar with GBD, for each disease, the way they capture, so mortality is easy to capture. So mortality is just based on how many years you've lost due to this disease from dying or from early premature mortality. And the morbidity part is based on, so each disease has a sequelae. So different types of symptoms or different types of like severity of the disease. So as I mentioned, cancer, for example, has 4 stages. And they actually, for each country and each disease, they capture, the kind of the distribution of this disease and the types of kind of the severity of the disease that the patients go through. And so then they add it up all together and create this metric. And so if this distribution of people having cancer, but in an earlier, less severe state than a more severe state, then the weighted sum, or the sum of the severity is smaller, right? And so you could see that over time. In cardiovascular diseases, also, even with certain diseases, then there are different severities, and so you can just sort of capture that and see that trend declining over time. And I think this is something that, for example, demographers cannot do, and demographers often don't really look at morbidity. they mostly focus on survival and mortality. And I think that's the strength of IHME work. And it will be, I'm sure people are doing it, I don't know yet, but how to measure population level, you know, the functionalities of morbidity of disease are very important. And IHME or the GBD at least has this technique of adding them together. And there may be more sophisticated ways to do so, but that's what I'm familiar with.
In doing a study like this, how much of a problem is it that perhaps, let's say in Papua New Guinea, you're less likely, if you have diabetes, less likely to be diagnosed than if you're, say, living in Switzerland? The difference of likelihood of receiving a diagnosis for a disease you have, how do you adjust for that? Or how much of a problem is that? Yeah,
so is your question more around, is it possible that Papua New Guinea is actually detecting lower rates of cardiovascular diseases?
Sure, or really more generic than that, but that's, yeah, a concrete example, you know, is the incident, I'm sure the incidence of diagnosis varies across countries, and that would therefore affect their reported burden as opposed to their actual burden. How do you deal with an issue like that?
Yeah, that's a very good question. It's more of a global burden of disease question that I can sort of answer, but not exactly. And so global burden of disease, they rely on a couple of data sources. One is country reported. Of course, certain countries like the US or Denmark, they have much granular administrative data that they can just use. For other countries, they use country reported data, but as you can imagine, either due to diagnosis, lack of diagnosis, lack of data collection, and so on, there may be gaps in quality. And so another way they kind of fix that is by modeling. So they have this very complicated and big model to try to smooth out the data, or try to figure out based on experts, based on country level data, of course, but also based on other estimates, either from neighboring countries, based on past trends. So they try to fit all these things together to figure out what is the most possible and reasonable prevalence of certain diseases. And so that's how they do it. And maybe this is not what you're getting at, but actually Papua New Guinea has high age-related burden. And so it is possible that their data collection and their quality of data may be poor, but IHME sort of use their method to figure out what they think is the right level of estimated burden. And
sort of a related question is, do all countries use the same definition to define a disease? And I'm thinking of a couple of examples. I know there's 3 different recommended criteria: World Health Organization, Endocrine Society, and ADA for definition of metabolic syndrome. And another example I've heard is that the incidence of MID versus AD in the US versus Japan is quite strikingly different. And no one quite understands if that's because the diseases are different or just because pathologists have grown up with different traditions of classification. So the question is, do all countries engage in diagnosing a disease with the same criteria?
So I'm not an expert in this, but my understanding is, so again, separating out mortality and morbidity, my understanding is that at least in high-income countries, mortality is a fairly straightforward way, because there is I think they use ICDs or certain standardized codes to document deaths. In in countries that may not be using those, I think again, they use sort of more modeling and trying to figure out with experts to figure out what to do. So I think mortality, maybe there is a coding issue in terms of what they deem as the primary reason for death. That could be different. I'm not so sure about that. The morbidity part is quite interesting in that they use diagnostic codes as well, but they also GBD uses this thing called the disability weights, which is for each disease, kind of layman term is like, how much weight do you put on having this disease versus another disease? So it's a fairly subjective view of how you would rank this. And you can imagine culturally, it might be very different. So some cultures may put more weights on depression than others. So it could be very culturally specific. However, so in maybe 10 years ago, they did this big study across multiple countries, online as well. And what they found is that actually across 6 or 7 countries with very different contexts, the severity, like kind of the disability weights, or so the ranking of these diseases were actually fairly consistent. So what was actually now interesting, I recently heard, is that they've been doing similar studies in different parts. So they did in Europe, they did a very thorough study in Europe, in South Korea, in Japan, and I think they're doing now in China. And I think in China and Japan, they actually found differences. And so they may be going to change or try to figure out what to do with it. The fact that morbidity could be partly subjective, and how do you account for that when you're comparing across countries. When you're doing national level studies, this doesn't matter so much. It's a way of kind of summing mortality and morbidity together. But when you're doing country comparisons, this could be an issue. But it's quite interesting, and I don't think they have it's an ongoing debate on how to do this well.
And Bill, I can add a little bit to that. That was some analogous work that I was on about 10 years ago. So as Angela was saying, we have ICD-10 codes for the mortality data, but for countries even that don't have great death registries or like autopsy function, one of the alternative ways that they were able to fill in some of those gaps is a technique called a verbal autopsy, when they actually go back to the places and speak with the family members or community members of a particular person that has died, trying to create a long symptom survey, and then using like machine learning compared with a physician diagnosis to come up with a potential cause of death. So yeah, there's some really neat work going on there in terms of how we can actually diagnose in settings that we don't have the same access to healthcare systems like high income countries like the US.
If there are any other questions, speak up now. Otherwise, we can wrap up. Thank you so much for taking the time to present this really interesting paper and to answer all of our questions. It's really, really interesting to have this global perspective, since we all live in our own small world. Thank you very, very much.
All right. Thank you.
Have a good day, everyone.
Bye.
Thank you.